All right. So most ptosis are congenital. To be very appropriate, 60% of them are congenital and 40% are acquired. Out of all congenital ptosis, 75% are unilateral and 25% are bilateral. And there are host of causes for acquired ptosis: neurogenic ptosis, myogenic, aponeurotic, mechanical, traumatic, and pseudotosis. What is pseudotosis? Pseudotosis means there is no actual ptosis, but there is an appearance of ptosis. There may be various causes for pseudotosis. One set of causes because lid tend to follow the eyeball. So if eyeball is not supporting the eyelid properly, then lid will naturally droop down. A very common condition is hypertrophy. In this particular person, in this boy, you are seeing left eye ptosis. But this left eye lid is following the eyeball position, and this eyeball has moved downward. So it's a pseudotosis because eyelid is following the position of eyeball, and classically if you occlude the right eye, left eye will take up the primary position and ptosis will improve. Similarly, you may have patient of microphthalmos, anophthalmos, phthisis bulbi, patient with smaller eyeball. There also lid will, eyeball will not able to support the eyelid, and there will be an appearance of ptosis, but actually there is no ptosis. Then there are conditions when there is droop of eyebrow, there is excessive skin which is causing an appearance of ptosis, but actually there is no ptosis. Then there may be bigger contralateral eyeball, and it is there in contralateral retraction. This patient is having left eye retraction, but it may give rise to a condition where a person may think patient is having right eye ptosis. Similarly, a patient of contralateral proptosis also may appear like having right eye ptosis, but it is actually a pseudotosis. Again, another condition, blepharospasm. In this particular patient also there is reduced palpable fissure. So this may mimic ptosis, but how one can differentiate blepharospasm with ptosis? In blepharospasm, there will be overriding of cornea by lower eyelid also. So both the eyelid will override cornea, upper eyelid will override upper part, and lower eyelid will override the lower part of cornea. So these are the causes of pseudotosis. Now we come to the ptosis. As I told you, most congenital ptosis are congenital, and out of all congenital ptosis, 90% of them are simple. We call them simple when ptosis is not associated with any other complication, any other ocular problem. If ptosis is associated with weakness of elevator muscles, then it will be called as complicated ptosis. A very common condition is known as double elevator palsy. Why it is there? Because elevator muscles and levator, they all develop from a single myotome, common myotome, and both of them, like they are supplied by common nerve, superior division of third nerve. So that's why you do get a condition of double elevator palsy along with ptosis. What are the elevators of eyeball? Superior rectus and inferior oblique. All right. Then there is another condition which is known as congenital synkinetic ptosis and also known as Marcus-Gunn ptosis, where there are aberrant connections between fifth nerve and third nerve, and this also falls into complicated ptosis. And then there may be some syndromes like blepharophimosis syndrome, where there is a tetrad of congenital ptosis, blepharophimosis, telecanthus, and epicanthus inversus. So these all conditions, they come into complicated ptosis. If none of them is there, then patient will be a case of congenital simple ptosis. So whenever you get a case of ptosis, an examiner asks you what is your case, what is the diagnosis of your case, and you say my case is of right eye ptosis, automatically examiner will frown at you and he'll judge that the boy or girl is not very good in subject. And if you tell diagnosis like this, that my patient is having right eye congenital simple partial ptosis, it means your patient is having congenital ptosis, which is simple, not complicated, not associated with any other problem, and partial because some amount of palpable fissure is there. you do not get a total ptosis. You very rarely get a total ptosis when almost complete closure of palpebral fissure is there. So mostly cases are of partial ptosis only. So if you explain your diagnosis like this, your 90% of case is over. And examiner will automatically think that this boy or girl has got metal. Blepharophimosis syndrome, I have told you, it's a syndrome where there is ptosis. Ptosis means decrease in vertical palpebral fissure. Then there is phimosis, which is there in the name itself. Phimosis is reduced horizontal palpebral fissure. Then there is telecanthus, increase in the intercanthal distance, and epicanthus inversus. This fold is there. So this is the classical tetrad which is there in blepharophimosis syndrome. There are other minor features also which are there in blepharophimosis syndrome. There may be ectropion of lateral half of lower eyelid and entropion of medial half of lower eyelid. So differential lid position is there in blepharophimosis syndrome. This is one of the very rare conditions wherein you get both entropion and ectropion in one single lid. So in this particular condition, you have got medial entropion and lateral ectropion of lower lid. Marcus-Gunn jaw winking ptosis, yet another cause of complicated ptosis. It is there in 5% of all congenital ptosis. Here there are aberrant connections between fifth nerve and third nerve, and stimulation of fifth nerve by contraction of pterygoid muscle will create excitation of third nerve and thereby elevation of ptotic eyelid. So there will be elevation of upper eyelid by opening of mouth or by stimulation of pterygoid, and all which is there by contralateral movement of jaw. We will discuss these things in little detail also. There are two major groups of Marcus-Gunn ptosis. One is external pterygoid levator synkinesis, where eyelid raises on jaw thrust to opposite side. External pterygoid is acting, or when jaw is projected forward on opening of jaw. So this is external pterygoid Marcus-Gunn phenomena. Patient is opening the jaw and lid is getting elevated. This particular patient is also having elevator palsy. She is looking up, but this eye is not moving up. Then there is another variety which is known as internal pterygoid type of Marcus-Gunn phenomena. Here, lid opens up when patient clinches his or her teeth. This is where internal pterygoid come into the action. So in this particular patient, now look, lid is opening on clinching of teeth. So this particular patient is having internal pterygoid type of synkinesis, which is less common than the external pterygoid. Then there is yet another phenomena which is known as inverse Marcus-Gunn phenomena, or also known as phenomena of Marie-Taman. Here, instead of ptosis, there is retraction on mouth opening. So nothing great, but you must know this name. In some of the quiz, you may be asked about this. Now we'll come to the evaluation of ptosis. Whenever you receive a patient of ptosis, obviously you need to take history, and history is important in cases of congenital acquired ptosis primarily. There may be history of diplopia in third nerve palsy, dysphagia in Marcus-Gunn ptosis, in myasthenia gravis ptosis, and other muscle weakness in myasthenia gravis ptosis. One very important history is use of steroid eye drop. Steroid eye drop may give rise to myogenic ptosis, and this is quite common after cataract surgery. So one must be aware about this particular cause. Also, you must be aware about kajal and mascara. Long-term use of kajal and mascara will also give rise to myogenic ptosis. Similarly, long-term use of contact lenses also may give rise to myogenic ptosis. One may ask you a question, what are the causes of post-cataract surgery ptosis? Previously, nowadays, superior rectus application is very, very limited in cataract surgery. So trauma to nerve by applying superior rectus is one of the cause. Then there may be some what's happening, bhai? Then there may be some dehiscence of levator aponeurosis also. This may occur even while applying and removing eye drape. Sometimes there is very very tough stickiness on the drape which we apply on the cataract surgery, and patient's eyelid is extremely thin. Old fragile patient's lid is extremely thin. When you remove the drape, it may create levator aponeurosis dehiscence also. I have seen one such case. So you must be aware about this particular cause also, and of course steroid eye drop use is very common. Now we come to the ptosis examination chart. In any case of ptosis, if you are giving your examination, you are supposed to make a chart, and if you make that chart properly, your case is done. Your examination is almost over. So what are the points we are supposed to check in a case of ptosis? See, before coming to the ptosis per se, you must see other things. First of all, you must be able to see patient from a distance, whether a person is having head posture or face turn. If a patient is having bilateral severe ptosis, then he or she will have chin elevation, because patient will have to elevate the chin to see properly. Similarly, if one eye ptosis is severe enough to cover the pupil, then there will be face turn to the normal, towards the normal side. If I am having ptosis in the right eye, I will keep my face like this to see better from the left eye. So head posture, face turn, then the frontalis action. Frontalis action, you will have to see the wrinkling on the forehead. Just try to make patient use his or her frontalis. This is important whenever we are contemplating frontalis sling. There are patients whom frontalis is not at all acting. In those patients, if you do frontalis sling, the effect will not be that much. So you will have to actually see whether frontalis is acting or not. Then the eyebrow position. In all severe ptosis, patient will keep his or her eyebrow arched. So you will have to see that. This may create some aberration in the ptosis measurement also. Then the lid crease, position of lid crease and lid fold, and lid margin, whether a patient is having entropion or ectropion or not. So we have not come to the ptosis till these points. There are these 5 points which are not related directly to the ptosis. So in our ptosis examination point chart, initial 5 points are not related to the ptosis per se. Now we have come to the ptosis, palpable fissure measurement. You will have to do horizontal and vertical palpable fissure measurement both. What is the cause of horizontal fissure narrowing? Blepharophimosis syndrome, correct. And horizontal fissure will be narrowed in all cases of ptosis. In vertical fissure measurement, you will have to take measurements in three gauges: primary gauge, up gauge and down gauge. These 3 gauges, the gauge measurement have got some importance. I will tell you what is that. Amount of ptosis, which is calculated based on 2 methods. One, difference in the vertical palpable fissure in primary gauge. Second, MRD1 method. What is MRD1? Difference between upper eyelid margin and corneal light reflex. Normal MRD1 is 4 to 5 millimeter. You will have to compare both the eyes MRD1, and whatever is the difference will be the amount of ptosis. If bilateral ptosis is there, then you will have to take measurement of normal person. 4 to 4.5 millimeter is the normal MRD1, and then calculate accordingly. Similarly, other method is palpable fissure method. Measure horizontal vertical palpable fissure in primary gauge in right eye and left eye, and whatever the difference is there, that will be the amount of ptosis. Now there are certain other points: levator function, lid lag, leg of thalamus. So what all points we have discussed? 5 points which are not related to ptosis: head posture, frontalis action, brow position, crease and fold position, and lid margin. Then 2 points related to ptosis per se: palpable fissure and amount of ptosis. Then there are 3 L: levator function, leg of thalamus, lid lag. So these 3 are 3 L. Then there will be 3 phenomena: Bell's phenomena, Marcus-Gunn phenomena, Alif phenomena. And then there will be 3 ancillary signs which are not related to ptosis: extraocular movement, corneal sensation, Sharma's test. And then there will be vision and pupil. So once again we revise points in ptosis chart: 5 points not related to ptosis: head posture, face turn, frontally section, brow position, lid margin, lid fold. Then 2 points directly related to ptosis itself: palpable fissure examination and amount of ptosis. 3L, levator function, lid lag, leg of thalamus. 3 phenomena: Bell's phenomena, Marcus-Gunn phenomena, Alif phenomena. 3 points, ancillary points not related to lid: extraocular movements, corneal sensation, Sharma test, and vision and pupil. So this will complete your ptosis chart. And if you make a chart like this and write readings of right eye here and left eye on the other column, this will complete your long case of ptosis and also gives you complete examination detail of ptosis. Now there is one mnemonic, bad sign. What is bad sign? It stands for Bell's poor, B, corneal anesthesia, and D for dry eye. So this mnemonic BAD stands for poor prognosis and ptosis surgery. Poor Bell's was initially considered as an absolute contraindication for any ptosis surgery. If one want to do any surgery, then planned undercorrection with silicone sling can be done. Similarly, corneal anesthesia patient, one must be very careful. There may be chances of exposure keratopathy. And dry eye patients also, they are poor prognostic patients. Now, eyelid crease. This crease is of importance because you make your incision on the eyelid crease itself. If there is no crease, we want to make crease by our surgery. We make incision at proposed sides of eyelid crease, and we deepen the crease by passing some sutures into the levator muscle stump. This will be discussed maybe in another talk on ptosis management. Absent lid crease is often there in poor levator function cases of congenital ptosis. If higher lid crease is there along with deep lid sulcus, this is there in aponeurotic ptosis. You can see very deep upper eyelid sulcus and deep lid crease, which signifies aponeurosis dehiscence. You can see cornea shining through also through the weak aponeurosis. Again, very deep sulcus there. क्या हो रहा है भाई? Sorry for this. Now, how to check? It's not coming completely, okay. MRD1 we have already discussed. Positive MRD1 when light reflex, lid margin is above the light reflex. Negative MRD1 when lid margin is covering the light reflex and you will have to elevate the lid to see the light reflex. So in this particular patient, MRD is -1 because we have to elevate lid to 1 millimeter to see the light reflex. So this is minus MRD. MRD2 is distance between lower lid margin and corneal light reflex. So a combination of MRD1 and MRD2 will give rise to palpable fissure. Mild ptosis when ptosis is 2 millimeter, moderate when it is 3 millimeter, and severe when it is 4 millimeter or more. Palpable fissure height, MRD1 plus MRD2. In women it is more. We all know women, they have got bigger eyes, beautiful eyes. So 9 to 12 millimeter in women, 9 to 10 in male. MRD3, it is the distance between upper eyelid margin and corneal light reflex. This sign is not of great importance. MLD has taken up part of MRD3. MLD is, it denotes levator action, and it is measured as distance between center of upper eyelid margin to 6 o'clock limbus in extreme up gauge. So patient is asked to look upward, then you check position of lower limbus at 6 o'clock with center of upper eyelid. Normal MLD is 9 mm. This roughly tells you about levator function. Now, how to measure levator function? Burke's method. Very important, you are supposed to do this test in your examination. You tell patient to look down. You place your thumb directly above the brow to stop frontalis from acting. Place a ruler and check the excursion of lid on the eyelid. These are the grades: less than 4 mm poor levator function, 5 to 7 fair, 8 to 12 good, and more than 12 is normal. Now, this particular diagram, which is taken from a textbook, this is telling you a wrong method to denote levator function, because here examiner is pulling the eyebrow up, and this will give you erroneous levator action, because you will be giving some amount of pull on levator by your thumb. You can see this eyebrow is pulled up by thumb. So, this is not the way it should be done. So, how it should be done? So, you will have to ask first patient to look down, then place your thumb directly pressing on the brow. Your thumb should not move up or pull down, and then ask patient to look up and check the excursion of eyelid on the scale. So, your thumb should be directly over the brow. You should not be pulling the brow or pushing the brow. So, this is the proper way of checking levator function. Incorrect way, which is being done by many people, you can see this thumb is pulling the brow up, and here now it is pushing the brow down. So, both the methods are inaccurate, and you will have inaccurate levator function. So, you should not be doing it. Now, there are certain features in congenital ptosis. There is malformation of levator function, it becomes dystrophic, there is some fibrous and adipose tissue in the muscle. So, neither these levators they are able to contract properly, nor they are able to relax properly. And this gives you this sign, lid lag, which is there in congenital ptosis. If lid lag is there, you are 100% sure that patient is having congenital ptosis, though around 25% of congenital ptosis patients, they do not have any lid lag. So, absence of lid lag will not tell you that a person is having congenital ptosis, but presence of lid lag will always tell you that a person is having congenital ptosis, because here lid lag is dystrophic and patient is not able to relax the eyelid also. How to measure lid lag? You measure palpable fissure in down gauge. In our ptosis examination chart, we have done measurement in primary gauge, up gauge and down gauge, palpable fissure measurement. Down gauge measurement and difference between two eyes, this will tell you about the lid lag. Now, these are the photographs of patient, primary gauge, up gauge and down gauge. We will have to measure palpable fissure in all three gauges. In down gauge, you can see this palpable fissure is much more than the normal. So, this eye levator is not able to relax properly, neither it is able to contract properly. So, this is a classical feature of congenital ptosis, and you have lid lag here. In this particular patient, 3 mm of lid lag is there. How we have come to this figure of 3 mm? Because of this difference in palpable fissure. Palpable fissure in down gauge in left eye is 8 mm and in right eye it is 5 mm. So, this 3 mm difference will tell you about the lid lag which a person is having. Ptosis is 5 mm. How we have come to the conclusion of, ptosis is 4 mm. How we have come to the conclusion of 4 mm ptosis? Yes, difference in palpable fissure in primary gauge is this 4 mm. Similarly, if we check MRD, right eye MRD is 5 mm and left eye MRD is 1 mm. So, again this difference is 4 mm. Now, what mistake is being committed by many students in exam is that reflexly, mechanically we are making our ptosis chart. We write here 10 and 6 and here we measure. Sometime while doing measurement, we may feel that it is 4 mm. So, we will write here right eye 4 mm, left eye 1 mm. Examiner will look at only, will try to find out these discrepancies only. So, he will say, oh, so your ptosis has changed. In your palpable fissure measurement, you have your ptosis is 4 mm, and according to this particular method, now your ptosis has become 3 mm. So one must be very careful that these two findings should corroborate. 4 mm ptosis will there 4 mm in MRD method also. What can change is your measurement. You may not be very accurate in one of them. So you must doubly check that your both these readings are corroborating with each other. You got this point? I hope it is clear, no? Yeah. Leg of thalamus, inability to close the lid completely. So it is again should be checked, because this leg of thalamus which is there preoperative is bound to increase after surgery. So if 2 mm of leg of thalamus is there before surgery, it will become 4 mm after surgery, and patient may have some corneal problems. So preoperative leg of thalamus, one has to be very careful. Bell's phenomena. Eyeball moves up and out on attempted lid closure. It is again very important in assessing post-operative corneal complications. Poor Bell's phenomena invariably want undercorrection or no surgery. How to check Bell's phenomena? I'll just tell you. Good Bell's when more than 2/3 of cornea disappears on attempted lid closure. Fair when 1/3 to 2/3 of cornea disappears, and poor when less than 1/3 of cornea disappears under the upper eyelid. Then there are various types of Bell's. Normal Bell's when cornea rolls up and out. Then inverse Bell's when cornea moves up and in. Then reverse Bell's when cornea rolls down. And perverse Bell's when sometime it goes up, sometime it goes down. Like you check Bell's 10 times, there will be different result every time. So this is known as perverse Bell's, bizarre directions. So one very important factor is, in many of the patients, before surgery you have got normal Bell's, after surgery it becomes reverse. And again after 1 month of surgery, it again becomes normal. Why it reverses after the surgery? It is because of nature's own correcting factors. Nature tried to protect cornea underneath the healthy eyelid. Upper eyelid becomes inflamed after surgery, swollen up. So nature automatically brings cornea downward towards the healthy eyelid. This is natural protective phenomena, and again it becomes normal. So one must see the Bell's phenomena, what is there before surgery and what is there after surgery. And this is how it is checked. You just pull the lid to normal limbus and then ask patient to close the eyelid. So you'll have to lift the ptotic eyelid to the limbus position and then ask patient to close. So you'll have to first lift the lid and then ask patient to close. Alif test, very simple test. You just invert the eyelid in down gaze. On looking up, lid will automatically return to normal with a snap. If levator function is poor, it will not return back with a snap immediately. It will remain inverted. And this is useful in children to judge poor levator function. If it is there, then we will make out that patient is having poor levator function. Marcus gun phenomena we have already discussed. Grading of Marcus gun. Mild Marcus gun when lid excursion is 2 mm. Moderate Marcus gun when lid excursion is 2 to 5 mm, and severe Marcus gun phenomena when it is more than 5 mm. Other way, when on movement of jaw, ptotic lid moves to the normal position, that is 1.5 or 2 mm below limbus. This is mild. And if on jaw movement, lid elevates to superior limbus, then moderate. And if there is scleral show on jaw movement, then it is severe. So two ways of grading Marcus gun phenomena. Acquired ptosis causes, we have already discussed few of them. Neurogenic, third nerve palsy or Horner syndrome, myogenic, myasthenia gravis. What are other causes of myogenic? Steroid induced, contact lens induced, kajal. Then there may be some dystrophies like CPEO and other dystrophies. Aponeurotic ptosis dehiscence, levator dehiscence, senile ptosis, mechanical ptosis, ptosis because of weight of lid as it is there in lid tumors, and traumatic ptosis obviously after trauma. Neurogenic ptosis, these are the causes. Common is first two, third nerve palsy and Horner syndrome. This is third nerve palsy, ptosis, eye has gone into abduction, not able to move up, not able to move down, not able to adduct. So all movements are restricted except adduction and also superior oblique if movement, if it is there functioning. Horner syndrome, mild ptosis, meiosis, pupil is constricted here. This will be the clinching finding. In long-standing cases, you may have anhidrosis of face and decreased iris pigmentation also. Phenylephrine test done in patient with Marcus-Gunn syndrome and Horner syndrome. You put a drop of phenylephrine into the eye. If Muller's muscle is functioning, then lid will lift. Why Marcus-Gunn ptosis is there? Why ptosis is there in Horner syndrome? Yes, because Muller's muscle is supplied by sympathetic nerve, first plexus of sympathetic nerve, and which get affected in Horner syndrome, and that's why there is ptosis. Muller's muscle give rise to only 2 millimeter of lid lift. So that's why classically in Horner syndrome, you will have only 2 millimeter of ptosis. Mild ptosis will always be there, not more than that. And similarly, this test will be negative in Horner syndrome. Causes of myogenic ptosis, myasthenia gravis, common cause, myotonic dystrophy, CPO, contactless wearer, I have told you, steroid drops, mascara users, trauma to LPS, other dystrophies. Marcus-Gunn ptosis, myasthenia gravis ptosis. You will have to differentiate myasthenia gravis with CPEO, chronic progressive external ophthalmoplegia, which is a common muscular dystrophy. How to differentiate these two conditions? CPO, classically the onset will be there in adolescent age group, 15 to 17 years of age. Myasthenia gravis, there are two peaks, one in child, other maybe in elderly also. Classically in myasthenia, the affection is asymmetrical. In CPO, it will be symmetrical. So in CPO, there will be gross limitation of movement, but hardly there will be diplopia, because both the lids, both the eyes, muscles, they will be involved symmetrically. While in myasthenia, there will not be that much limitation of movement, but it will be frequently asymmetrical and more often than not unilateral. So there will be diplopia. Complaint of diplopia is commonly there in myasthenia gravis patient along with ptosis. Classically, it will have diurnal variation. It will be worsened by prolonged uses of eyelid, prolonged upgaze movement, fatigue. There will be positive Cogan lid twitch sign. Here you ask patient to move lid up after down gaze, and there will be classical upshoot, overshoot of upper eyelid. This is because of overacting saccadic movements in myasthenia gravis. Then very important test is ice pack test. This can be done in OPD. I'll tell you how it is done. Then tensilon test or neostigmine test. Tensilon, which is a trade name of atrophonium chloride. Unfortunately, it is not available in India, so we have to resort to neostigmine test. Then these are the blood test, acetylcholine receptor antibody test, which can be done from serum, quite costly, but can be done. Then there will be decremental response on RNS test, repetitive nerve stimulation test, and EMG. And CT or MRI can be done to rule out thymoma. Now, how to do ice pack test? You have got a patient of acquired ptosis. Just make patient sit in your OPD with application of ice packs in both the lids, and you will have improvement of ptosis after 5 minutes. So it's a very simple test, but sensitivity of this test is quite high. So very useful test. Tensilon test. The difference between neostigmine and tensilon, I hope you know about neostigmine and adrophonium. So the difference is while conducting these two tests, this is done intramuscular, this is done intravenous. do not let your anesthetist do neostigmine test blindly, because they are in habit of using neostigmine IV. They give neostigmine as a reversal agent in their anesthesia patients. So they require to give it IV. While we are just checking for myasthenia gravis, if you give IV neostigmine, there will be all problems, lot of muscular twitching, contraction all over, and patient will have terrible side effects. You will have to keep patient in the OT for quite some time. So how neostigmine test is done? Maximum dose is 1.5 milligram. It is given 0.04 milligram per kg body weight, IM, and check effect after 15 to 30 minutes. Before giving neostigmine, better to give IV atropine just to counter the side effect of neostigmine. So first apply a cannula, give IV atropine, then inject neostigmine IM, maximum dose 1.5 milligram, check effect, take photograph pre-neostigmine and post-neostigmine and check them after 15 to 30 minutes. There will be improvement in ptosis if it is positive. Hydrophonium chloride test, tensilon test, immediate result. You inject hydrophonium IV, first give 2 milligram of hydrophonium IV. While injecting only, you will be able to see the lift. And then give rest of the 8 milligram if there is no side effect. These are the side effects: dizziness, involuntary this. Most common is twitching of face and all muscle contractions. Curtain sign, again it is there in basically myasthenia gravis also and other acquired ptosis also. It is based on the Herring's law. So what is there here? Manually you raise the more ptotic lid. This will cause relaxation of both the eyelid, and eye which is having less ptosis will also droop. So you will have apparent bilateral ptosis, actually which initially you must be thinking that patient is having unilateral ptosis. So unilateral ptosis may become bilateral if you perform curtain test. Then myotonic dystrophy, a syndrome where you have got ptosis with facial weakness, other features like baldness, hypogonadism, presenile cataract, etc. Very important finding is that you shake hand with the patient and you are unable to release the grasp of patient because of muscle wasting. CPEO, I have already told you, this is a common muscular dystrophy. Symmetrical involvement, muscle movements are also restricted along with ptosis. Unfortunately, there is no treatment. Bell's is poor in these patients, so you will have to do planned undercorrection, and silicone rod is a very useful procedure. One important syndrome is Kearns-Sayre syndrome. Here you have got pigmentary retinopathy with conductive heart problems along with CPEO. So Kearns-Sayre syndrome is a triad of pigmentary retinopathy, RP-like syndrome with heart problems along with eye problems. And as I told you, it is symmetrical disease, so there is no diplopia in this particular condition. Aponeurotic ptosis, we have already discussed. There are various causes: involutional ptosis or senile ptosis, postoperative ptosis, blepharochalasis resulting into it, and trauma creating aponeurotic ptosis. These are some of the photographs of aponeurotic ptosis. Classically, you have got high lid crease and deep sulcus. This is quite deep sulcus. Mechanical ptosis, ptosis due to excessive weight, seen in lid tumor, chalazion, lid edema, etc. So thank you.